Everyone to this month's CPD session. Firstly, we acknowledge that the CHAP team is spread across many of the traditional lands. We pay respect to all traditional owners of these lands and those who under custodial law are charged with nurturing and protecting country. We pay respect to the elders past, present, and emerging. And so for those of you who are new to this CPD program, I'm Dr. Joyce Ramos, and I'm the facilitator for these monthly CPD sessions on behalf of the CHAP team. So this session is focused on Module 8 of the Cardiac Rehabilitation Guideline on psychosocial well-being. So first we have Professor Adam Scott as our main speaker, followed by our Service of the Month presentation. So Adam is the Director of Cardiac Sciences at the Royal Brisbane and Women's Hospital, and is one of the founding fathers of modern telehealth in Australia, and found inspiration to create White Cloud, which is a Queensland-based not-for-profit organization that provides practical support, easy access to treatment, and early intervention program for people with or at risk of developing depression and anxiety in its many forms. So his today is titled Tele-cardiac investigations and tele-mental health solutions for country cardiac patient. So over to you now, Adam. So I'll just stop sharing my screen. You can do your screen.
Mute. Okay. I'm good to go. Sorry, I'm just juggling multiple areas here at the moment. Oh, I've just lost my screen. There it is. Okay. So hi, everyone. My name's Adam Scott. I am currently sitting in Brisbane. I'm a massive fan of South Australia. I was last year with my son, who is a K1 paddler. We were at West Lakes for Nationals, and it was cold, but it was a cracking session. We had an awesome time. So today I'm here to talk to you about telehealth and its many forms of how you currently are utilising it here in Queensland. So the key focus we have in Queensland is around, and many of you will be the same, is around implementing value-based healthcare, which is all around, if we keep doing what we've always done, we'll keep getting the same result. So every decision we make, well, I make in my cardiology program and within White Cloud Foundation, is we run the decision, is this decision best by the patient? And if our decision is not best by the patient, it's best by the clinician or it's best by something else, then we need to change our decision and what we're going to do so that we're creating services so that, is it best by the patient that they travel 1,000 kilometres to access an investigation? No, that's not best. So we have to change our decision. Can we do it locally? And so they don't have to travel? Yes. Well, that's a good decision. That's best by the patient. So we run this rule over all of our decision making, and it's enabled us to really transparently and clearly think about how we provide healthcare. So the idea of today is about planting that seed with all of you to start thinking about your areas that you can innovate and not keep doing what we've always done and keep getting the same result, but tweaking what you're currently doing so that you get a different result, so it's best by the patient. And we've found the best way to do that is to unite the clans. We're really passionate about listening to all of our partners and consumers and hearing the good, the bad, and the ugly to understand what's working, what's not working, so we can be really agile in changing the way we deliver service so that it's best by the patient and also best by that local treating team in that rural or remote facility. And by uniting the clans, we're able to build these long-term, strong relationships of trust so that we remove all of the agendas, all the personal agendas, the politics, the turf wars. We are not interested in that whatsoever. And so we have a very big mandate about working with the willing to work together to find solutions. So today I'm going to start off talking about cardiovascular disease, which all of you are right across, but I'm going to look at it from a bit of a different angle. So we know cardiovascular disease is the leading cause of death globally. It kills 1 Australian every 12 minutes, and it's the leading cause of death for both men and women in Queensland.
Sorry, Adam.
Yep.
Sorry to interrupt. We just can't see your slides.
Oh, what? I was just about to say, how amazing is PowerPoint that it can. So what can you see? Can you see anything, or is it just white screen?
You.
You can see me. Oh, is it stopped sharing? Hang on a second. How do I get that big screen back up?
Not that we needed the slides. It was very clear.
Oh, it stopped sharing for some reason. Can you see them now?
Yeah, fantastic. Thank you.
Okay, so let me go back. Can you see that one there? We're all good. Okay, so cardiovascular disease, leading cause of death globally. It kills an Australian every 12 minutes and is the leading cause of death for both men and women in Queensland. So the area that we focused on within Queensland is our northwest, central west region of Queensland, which covers roughly just under 700,000 square kilometres of land, which is absolutely massive. And in this location, we know that the population, oh, hang on, my slides are going everywhere. Sorry. There we are. So the population of this northwest, central west region is 43,000 people. Now, when we compare that same region of land size in Europe, you're looking at a geographic area of France, Belgium, Luxembourg, and half of Switzerland. So those European countries have a population of just over 83 million people, whereas that western area of Queensland has a population of 43,000 people, which when we look at that and put that into context, is the same as the Marshall Islands in the Pacific Ocean. Bearing in mind the Marshall Islands have a much larger population, but a teeny tiny geographic footprint compared to this large location. So what this means is it's really challenging and difficult to provide specialist cardiac investigations in these rural locations. We know rural populations have higher rates of cardiovascular disease. There's a 25% higher morbidity and mortality in these locations, with an average 7-year lower lifespan. And this is generally due to a reduced access to primary healthcare, no specialist staff on hand to conduct and report tests, and we end up seeing patients travel long distances to access healthcare, and that alone results in social dislocation, financial burden, having to take sick leave from jobs, having to find care for their children, long wait periods to access the testing, and long reporting times to get the results back. So how do we ensure that a population in a remote or rural area can access cardiology specialty services on par with metropolitan areas so that we get rid of that urban and rural disparity? We go back to the future. So let's go back to 1905. Willem Einthoven conducted the first telecardiogram when impulses were transmitted from a telephone wire from the patient in the hospital to his lab some distance away. This quite, to talk about this openly, this is incredible. 1905, they're doing investigations via telehealth. And it now then took 117 years later where we went, right, let's advance upon Einthoven's work and use this technology to expand from a telecardiogram to create a telecardiac investigations program. So the idea of our telecardiac investigations program was it was created to remove the urban and rural disparity. We wanted to provide cardiac investigations via telehealth to enable same-day access and same-day reporting for all of our populations in those rural locations. We created solutions by listening and working closely to our rural and remote colleagues to really understand the complexity of their region. Too often in Queensland, our metropolitan hospitals communicate what they think should happen in these rural and remote locations with having no idea about the resourcing or the complexities that these local, small, rural regions face. So it was really important to us to listen to what their problems were, understand them, and then develop and customize solutions together. So we would listen to their problems. I'd lay out all these solutions on a table, and then we would work together to customize the approach per facility. So it's not a come one, come all, one size fits all. It is literally a customized approach per facility. And it was all based on very open transparency and communications, with all of our decisions passing the rule, is this decision best by the patient? So the first test we came up with was tele-exercise stress testing. What we knew and listened to from our rural partners in Longreach was that they did 2 stress tests once a month on a Thursday on the 3rd week of the month. And so if you're number 12 that's presenting to the GP and needing a stress test, you're waiting a long period of time to be able to access that stress test. And so what happened during that stress test is we all know that when you do low volumes of any procedure, you de-skill and you lose that skill, or if you've got a very mobile staff which come in and out of roles, that the quality of the performance of the test is sometimes not up to the diagnostic standard to get a proper result. So inevitably what would happen is a test would be done, the result printed out, it would be put in the mail and sent into a metropolitan facility for reporting, where inevitably it'd sit on a consultant's desk for a very long period of time. And then the result would be signed off, corrected, or said, this is a non-diagnostic quality test, needs to be repeated. So the result would be mailed back to Longreach, and Longreach would get the result, whereupon if it was a positive test result, then they'd have to negotiate with Brisbane to get that patient flown to Brisbane for an angio or a further interventional procedure. Or if it was a non-diagnostic result, they'd get on the bus for 29 hours to Rockhampton to have the test repeated or have another investigation done, 29 hours back, or they'd fly to Brisbane, fly to Rockhampton, fly back. And then once they go back to Longreach, all of their future outpatient appointments, if it had been done in Rockhampton, would be done back in Rockhampton. So they'd fly back to Brisbane, back to Rockhampton, which is huge amounts of travel. And so, when we started this program, I thought, if my parents lived out there, I'd be appalled that they couldn't access this level of care and had to travel so much. And so my parents don't live there, but someone else's parents do. And that's what made me go, right, we've got the creativity and the motivation to be able to create these solutions. Let's test them and pilot them. And so that's what we did with Longreach. We have, as you can see on the images here, we have a senior cardiac scientist and an advanced trainee cardiology registrar, and they are alive and present in the room with the local treating team, whereas a GP and a nurse at Longreach. And this happened to be our health minister at the time, who was having a stress test. And so you can see the team on the other screen where the health minister is lying down on the bed. But what the beauty of this system is that the senior cardiac scientist, they can see the real-time images occurring as the stress test is occurring. So there's 4 people in the room watching these stress tests, of which 2 of them are highly specialized in conducting the test, getting a diagnostic result, and reporting it. And the beauty of this program is we've further enabled it so that if the local treating team are on leave or the local treating team don't know how to do a stress test, we can remote control operate their whole stress testing system from Brisbane. So what they do is turn the machine on, we remote into their computer, into their stress testing system, they accept us, and then we type all the patient details in, we program the test of what we're going to do, we do the ECGs, the blood pressures, all automated, we start the treadmill, and the local treating team just put the electrodes on the patient, move them to the treadmill, move them off the treadmill. Once we've completed that test, the scientist will direct report into their stress testing system, and then the advanced trainee cardiology registrar will electronically sign it. So they'll print it. So within 7 minutes of finishing the test, the local treating team has a cardiology signed report in their hands, and then we will remote upload from that stress testing system direct into the viewer. And the viewer is a Queensland-wide GP or general health access. So any GP can log in and look up the patient and find out if they've had a stress test and see the full report with the recommendations on the report. So that really transformed for those rural locations. Previously, they had to wait on average 3 months to be able to access a test and get the results back, signed back. So the other test that we do is Telehealth Monitoring, and it works in the same way. We have a specialist team at the Royal Brisbane and Women's Hospital, and then we will have the patient in a remote location, and we will work closely with the nurse who will apply the electrodes. Our team remote into that monitor and we'll program it for the nurse. So we're trying to take all the IT complexity out for the local team. If they're not comfortable with a lot of the IT and the technology, then all we ask them to do is turn the machine on, and then we remote into that system, program it, and make sure we can see the real-time images and that we're collecting all the appropriate information we need so that we can then do a report. So what the beauty of this is this patient will turn up to Longreach or 22 of our other regional remote rural facilities. They turn up to that facility, they have the Holter monitor put on, programmed by the cardiac scientist. Patient then goes home to their bed. They come back the next day. The nurse takes the electrodes off, plugs the Holter monitor into a Queensland Health computer, and then our scientist will remote into that computer and then direct upload all of the data that's on that computer straight back to us here at the Royal Brisbane Women's Hospital, where we then report it straight away, and we will then electronically sign it with the Advanced Trainee Cardiology Registrar going through it and signing it off. If there are any positive outcomes from these tests, so if we pick up some major pauses or tachycardic episodes which need more specialist attention, what we do is we have the registrar then work as the facilitator to transmit that patient who may be at Doomadgee or Mornington Island in a very remote location, communicate with their local treating team so they understand what's happened during the test, what the results are, and what the next steps are. And they facilitate getting that patient from their local area to their normal referral treating hospital. So for example, if they're in Northwest Queensland, their normal referral pathway will be to Townsville Hospital. And so the registrar will work with the Townsville team to get that patient to Townsville, get an intervention done, and then get that patient back out with all their results back out to their local treating team with that information. Because quite often we have outreach teams going out to these rural locations, treating patients, bringing patients back to Brisbane and treating them and then sending them back home. And the local GP knows nothing of it, doesn't even know they've had a pacemaker in or a procedure done. So what we try to do is be very transparent in the facility. The normal referral hospital that they would go to stays in contact and in play. We don't want any of these patients brought back to Brisbane. We want them to maintain their relationships with their local referral hospital so that everybody is aware of what's going on. All that we do is we facilitate the rapid access to the testing so that the local treating team can get the results they need when they need it. And the big one for us is we've had some incredible outcomes. So we turned this system on in 2016 with one site with Longreach Hospital, and we're now operating with 22 facilities across regional, rural and remote Queensland. We do around 1,800 occasions of service a year between stress testing and Holter monitoring. But the big one for us that we absolutely love is we've seen this huge increase in uptake in our First Nations community. And the reason why that is we listen to them. They want to stay in country to be able to access the care they need, not have to travel flights, drive long distances, 400 kilometres to access a test. So we facilitated enabling the 24-hour Holter monitoring to be done in country in their First Nations community so that they could get the test done when they need it, where they need it. So on average, when we looked at that central west and northwest region of Queensland, patients waited on average 37 days from the time they presented to their GP till the time that they got their test performed. And so the implementation of this Tele-cardiac program has meant we now provide same-day access. So if they present to a GP, they can go and have a stress test or a Holter that day, or if it's late in the day, they can have it first thing the next morning. The other big one was the reduction in reporting time. So quite often, because they're very regional remote, they would send their data to a metropolitan location, usually via snail mail, where the metropolitan team would get around to reporting it because they've got their own catchment and work to get on top of, and are generally not funded or resourced to support the rural areas. So they would report it and then send it back. So that used to take 36 days after they'd had the test done. And now, on average, we find we can get the report back for a stress test within 27 minutes, depending on the complexity and what needs to be discussed and move forward, right through to, and for stress testing, it's literally 7 minutes post-stress test. So what we've seen is a huge reduction in patient and carer travel. So on average per patient, around 140 kilometres saved, with since 2016, a total saving of about 320,000 kilometres, or 8 times around the world in patient travel. And this obviously has resulted in a cost saving from reduced travel of about just under $400 per patient, which is absolutely massive when it comes to the health system and managing resources. And so the really big one for us that's important is that 83% of patients now don't travel past their local health facility to go to a larger health facility to have a test performed. So that's the patient travel is, when you live in a metropolitan location and you drive 6 minutes to your GP practice, you don't think about, what do you mean travel to appointment? It's just 6 minutes away. Whereas, for some of these locations, you're traveling 14 hours to drive from one location to another to get a test done, which we have a large amount of road accidents just from people traveling to a medical appointment in these very, very rural areas. We're really big on listening to our consumers and our patients. And so we're proud to say we've got a positive patient satisfaction rating of 4.9 out of 5 stars. And we're always trying to get to 5 stars because it's really important. We were very proud to publish this in the New England Journal of Medicine 2020, which was a fantastic outcome to be able to get it widespread and spread around. Now, what I'm going to play for you now, and I hope this works. The sound usually doesn't come through, but this is Bernie, who was one of our patients in Longreach, who he was wiping down the walls of his shed, got some chest pain, went to his GP. The GP said, "Hey, we've got this fantastic new program where you can go and have a stress test right now." So he went and had a stress test, and he had a very, very positive one, to the point that we activated RFDS and got him brought down. So he had a stress test in the morning, he was medevaced out at lunchtime, and by that afternoon, he was in Brisbane having an angiogram, and then the next day he went on to have a triple bypass. And this is what Bernie had to say. And so Bernie's a champion. So he's been a bit of a poster boy for us. He's such a great guy. He's well known within the community. So he's a huge advocate of our services and what we're doing out there with them. But the beauty of this is previously he wouldn't have got that stress test for another 2 to 3 months, not got a positive result from it. And so he eventually may have had a very poor outcome from it. But now, we got him in, we did an angio, we got his bypass. 2 weeks later, he was discharged back to Longreach, and all of his future outpatient appointments are now done via telehealth. So he doesn't have to leave Longreach again to have to fly back in, whereas previously he'd fly back into Brisbane every couple of months to be able to have that outpatient appointment. So we're really trying to work out the best way to deliver care for our patients. I'm bearing the time, I'll keep going. Let me talk about our telemental health solution. So 10 years ago, I created, I had a lot of friends and family living with or suffering from depression. And when I walked their journey with them and walked in their footsteps and listened to them, we realized it was really, really hard to access early practical support and solutions. And it still is today. To get on a mental health care plan, you have to go and be diagnosed, which can affect your insurance. You then get a referral to a psychologist. In Queensland, it's up to 3 to 6 months to access a psychologist. And then generally there's a big gap payment to pay for it. So when you're having a mental health issue, you can't wait 3 to 6 months. It's like when you break your leg, we don't go, just bandage it up and we'll look at it in 3 to 6 months time. So we can't do this when people are having a mental health issue. So I went, right, I looked at how we deliver care and looked at our value-based healthcare approach and really focused on integrated practice units. So rather than have one discipline hold that patient in a silo, it was about multiple disciplines working together from different angles to provide that holistic approach. And so White Cloud was created. We now have a huge perinatal program where we have 75 institutions in Queensland that refer mothers who are living with or at risk of perinatal depression to White Cloud Foundation. We provide them with 14 frozen gourmet meals that they choose, delivered to their door, and a whole raft of that social connection to support them during that time of need. And we've also developed this telemental health service. So I'll quickly go through these. Sorry, I'm bearing the time. So our telemental health service was all based around removing the barriers to accessing treatment. So to access this service, it's a local phone number, 3155 3456. You don't require a diagnosis. You don't need a referral. It's free. It's no travel. And it's a very discreet medical program as per a standard medical clinic. So we utilize a team of psychology, social work, dietetics, exercise physiology, counseling, mental health nursing, and wellness coaching to be able to provide a holistic approach in treating the person. So we launched this program just over a year ago at Longreach with the intent of really focusing in and supporting our rural locations, because that's what we were hearing from them, was that they needed more mental health support. We've since branched out, and we recognize that sport is a huge pathway for recognizing when a mate's struggling or a teammate is in a bit of a battle. And so we have partnered with a whole raft of different sporting associations, and what we're providing them is every single member of Queensland Rugby or Paddle Queensland, whether they be a staff member, a general member, an athlete, a coach, an administrator, or even if you're the butcher that provides the meat tray for the raffle for a club event. If you're part of that sporting community, then this is your pathway to be able to access mental health treatment early when you've got the speed wobbles, because we don't want people to have the speed wobbles and then not get them in control. And we all know what happens when you're on a skateboard and you get the speed wobbles and you get out of control, you crash. So our idea is to be able to stabilize that person by using all of those different disciplines to wrap around the individual, to give them the right support they need, when they need it, where they need it, so that it's easy to access mental health care support. We recognize that we're here to complement existing services. So supporting GP practices that are doing great work, supporting health facilities that are doing great work. What we're trying to do is be that gap, or be in the gap when people fall through the system and can't access support or won't access support. This gives them another option where they can actively go and seek out that support and get the treatment they need. So how do we get there? It's a long road, but the key is we do it as a team. If I say to my team, we're all in this together, we're all in the same boat. If the boat sinks, we all sink together, okay? There's no I in team. We're really focused on looking after and supporting each other. And if it's successful, we as a team are successful together. And it's not just the clinicians, it's the patients, it's the administrators, it's the wardie, it's the patient food service, it's everybody that enables that patient to get the care they need. But I might stop there because I'm aware that we're running short on time. So I'm happy to take any questions as we keep progressing in the session.
Oh, what a fantastic presentation, Adam. That really felt like a TED Talk to me. All right. In the essence of time, we'll carry on with our service of the month, but the audience will have an opportunity to ask you some questions right at the end. Okay, Adam?
No problem.
Okay. Well, I'll just share my screen again. Okay. Hear me. There we go. All right, so next up, we have our service of the month presented by Alyssia Smith from Eyre and Far North Local Health Network from Port Lincoln. Alyssia has been a registered nurse for 17 years and worked as a cardiac or pulmonary rehab nurse in Port Lincoln for 10 years. So now over to you, Alyssia.
Hi, thanks for having me. So as you can see on the map, Port Lincoln is right down the bottom of South Australia, and the pointy end of the triangle. We are a 7-hour drive from Adelaide and a 40-minute flight from Adelaide, but a very expensive flight, anywhere from $120 to $300 one way. So we're very accessible, but still a long way away. We're also probably known by most people as the seafood capital of Australia. We have a large prawn, tuna, fishing fleet. We're also home of the shark cage diving. For those of you that have been to Port Lincoln, I'm sure you've probably done the shark cage diving. So just moving on to the next slide. Thank you. So Port Lincoln, we have a population of 1,500 people. Our main industry, as I said, is fishing, farming and agriculture. The photo at the top there is our hospital. We had a newly renovated hospital about 7 years ago. We have 42 beds of acute. We have a renal and a chemo unit. We do obstetrics and general surgery. So Eyre Far North Lower Health Network Service, we are on the map on the right-hand side, the dark orange. So we are a huge area of over 300,000 square kilometres, and with a population of just over 40,000 people. So I am the only cardiac rehab program for our whole region. So we do our very best. We're based, cardiac and pulmonary rehabs based on the ground floor of the hospital in community health. So we sit in a pod set up office of 50 desks with all other allied health professionals, including physios, community nurses, occupational therapists, speech pathologists, dietetics, palliative care, breast care, social work, diabetes nurse, NDIS, ACAT. So we're all in one big office. So you can imagine it's quite noisy, which is why I'm in a quiet room now. So next slide. So I work, for those that aren't familiar with Better Care in the Community, a lot of the cardiac rehab programs in South Australia run under Better Care in the Community. So we have a Better Care and the Community nurse, Leonie, who works 0.9. I run cardiac and pulmonary rehab at 0.7. So I actually only really have about 0.35 time to do cardiac rehab. We have a physio that helps with the cardiac and pulmonary rehab programs for 2 hours for each session. And also just recently we've managed to get an allied health assistant to help as well for each group. We don't have any admin support, so everything we do is done by us. So next slide. So cardiac rehab we run in the hospital in community health in the physiotherapy gym. So clients come in each Tuesday from 1 o'clock to 3 o'clock and we run an 8-week block program, which seems to work better than a rolling program in our area. So we allow the first hour of the program for a guest speaker. So each week we have either a physio, myself, we have a dietitian, a diabetes nurse educator, a social worker and a pharmacist who all give education on their relevant area. Then the second hour we dedicate to exercise in the gym with a warm-up and cool-down, which is run mostly by a physio or myself. So there's some photos there from last week with a few of our clients in the gym. So I accept all referrals of any cardiac condition, and all clients are offered a one-on-one cardiac assessment and education session. So it's quite hard to, when people live 200-300 kilometres away, it's often a phone call to them, and then try and organise if they're ever coming to Port Lincoln to catch up one-on-one, or we do our best offering telephone cardiac rehab or web-based. So complex heart failure clients, we really utilise VCC, virtual clinical care, which we just couldn't live without anymore. We find them so helpful, and those frequent flyer heart failure clients especially that come in, we rarely see them again after they've been on VCC. So my role as cardiac rehab nurse, I'll receive a referral from our CATCH database, or from a GP, or a self-referral of a friend that's come to cardiac rehab before. I then straight away send out a letter detailing the options of cardiac rehab. So we have face-to-face program, we have the face-to-face, the CATCH telephone program, chat web program, or if people aren't really that keen on the cardiac rehab, I still offer a one-on-one assessment for education. Due to being poor time and having not enough time to do all the admin required, if I don't hear back from that client, and I do write that in the letter, that I'll close their referral. So the second someone receives their letter and wants to join in, they give me a phone call, we book them in for their cardiac assessment. which is then a pre-assessment for the cardiac rehab program, and we do our 6-minute walks as well. Then we offer that ongoing support during cardiac rehab. At the end of the program, do a post-assessment and refer on to other services as necessary. Our Better Care and the community nurse attends the wards daily, looking to help people get out of hospital, using hospital avoidance strategies, setting up clients on VCC. We also manage home oxygen in our community and do yearly assessments and education for that. We also do RIBS funding, rapid intense brokerage support funding, which we're trying to push into the community nurses. Better Care Nurse supports the cardiac and pulmonary rehab programs and also does home visits for chronic condition clients that aren't on VCC. And we also access A&E records every day and look for people that have come in with either heart or lung issues, which then refer to me for them to follow up. So we really try and be seen, keeping people out of hospital and doing education. So just a few statistics. So for the last financial year, up and from July last year to June this year, I had 126 cardiac referrals, although I'm not sure if other sites have had this influx of referrals in the last few months now that we've opened up programs again, but I've had, I think it was 31 referrals in the last 2 months that we have just been slammed with, as well as another 20 pulmonary rehab referrals. So it keeps us very busy. We currently have 11 VCC clients happening at the moment, and we've, as you can see, 352 Better Care referrals in that year of people that we've referred to ourselves and followed up, or then become part of cardiac and pulmonary rehab. Next slide. So with COVID, we shut down our program sort of as December last year, and we have just restarted in August our face-to-face groups. So clients now are coming in, anyone can walk into our hospital. There's no exact screening, but clients are encouraged to rat test at home if they're unsure and stay away if they're unwell, and people are really respecting that, as they're just so grateful to be back in the gym and doing the program. So during COVID, I did mostly telephone consults, and for those people that were screened could come in for a one-on-one education session. I did encourage people for telephone cardiac rehab and did try with chat web. Unfortunately, I only had a few clients that sort of took on Catch Web that completed that, but I really didn't put in probably enough effort, as I was just time poor to try and follow up clients on that program. I'm in the process of setting up telehealth. It's just tricky without any IT or admin support, but that's in the cards to get that happening soon, as I do support a lot of people in regional areas that are 300-400 kilometres away. A lot of them, a few of them would often go to the Catch telephone program, or often people are always coming to Port Lincoln at some stage in the next month and will ring me and I'll see them face to face as well. I do send a lot of resources, and I've really tried to train a lot of nurses in those areas to set clients up on VCC too if they've got other chronic condition problems. Sejuna's a regional sort of town up the top of our region, who they automatically have their referrals go to Catch Web, although I do have clients coming down just to do spirometries and things, more so pulmonary side, but people that do want still that face-to-face education, if they're coming to Port Lincoln, they will catch up with me as well. Social isolation is probably a huge problem for our region with such poor internet service. So, and people that aren't IT savvy find it difficult even with Health Direct appointments and things like that. So poor internet connection, not having availabilities in their very small regional towns of support from carers as such, and just that distance to travel and the increasing fuel prices make it quite difficult for clients to get that access. So that's really all from me. Yeah, if there's any questions.
Great, thank you, Alyssia. That was very, very comprehensive. So I'll now open to everyone some questions for both our speakers. Any questions from the floor?
Hi, Joyce.
Hi, Alini. Go ahead.
You can recognize me by the accent, yeah. I would like first to congratulate both Adam and Alyssia on the programs. They are really fantastic, and thank you very much for sharing. And my question is to Adam regarding your Tele-cardiac program. Have you assessed satisfaction of the professionals and some sort of capacity building? Because I can see if you have the nurse and the GP there with the patient and running the stress test, this is a great opportunity for their capacity building. So I was wondering if you have assessed in terms of this.
So we haven't formally gone down that pathway to assess that with the clinicians, but what we've done is we've listened to them at every step of the way. So the big one they love is they actually get education during the testing procedure, after the testing procedure. The registrar, we encourage them to think that the registrar that is sitting there, the cardiology registrar that's sitting there with them during the test, is their registrar. And so they're able to work together and understand, educate each other around what the deficiencies are in their locations and what we have here in the metropolitan location, and try and find a happy medium between the two. The executive from the facilities love it because we've not taken a you'll do it this way. It's very much a, hey, what are your problems? How about all of these different solutions? And it's more the engagement and the interaction of how we participate with them, rather than telling them and dictating what they should do or how they should do it, is we recognize they've got a complexity and a resourcing we know nothing of, so can't speak to it. So we're very much guided by them. And so from a relationship perspective, it's really, really open and very transparent.
Yeah, seems to be a fantastic model. Thank you.
Okay, we have another question from Karen. Go ahead, Karen.
Thank you. It's very interesting to hear about those programs, because I'm currently trying to provide remote cardiac rehab into Alice Springs. So I only just been in there a few weeks. So yeah, I would love to have access to, the clients that I see have access to those sort of screening things, which unfortunately in the Northern Territory is not in play. And my other question, I guess, is to Alyssia. You mentioned you were looking at setting up some telehealth cardiac rehab with limited resources, which I guess is a little bit about my position at the moment. What sort of avenues are you looking at and to try and access, or provide a program when you've got very limited resources? Have you got any hints?
Well, just yesterday, one of the physios had done some training with Health Direct, and they were setting up like an online group, which seemed to be a lot simpler than other sites that get clients to go into the regional hospital or community health settings and link in with an allied health professional there helping with exercises and things like that. So we're hoping just to basically televise the education session and the exercise session, but so people can access that in their homes. So happy to email you when I know what I'm doing and get that up and running.
Yeah, anything you know would be great, helpful. Thank you.
No worries.
Okay, we have another question from Sherry. Go ahead, Sherry.
Hello, it's Kerry. My question is to Adam. Adam, with this way you're delivering, we currently, even living in Murray Bridge, we have a lot of IT issues. How did you get through the IT problems, and do they present quite regularly with your service and what you can deliver? Or have you sort of been able to navigate that hurdle and get better coverage?
That's a great question. So we within Queensland Health have a Queensland Health network, And so we have a lag time of about 0.05 seconds behind what is occurring out there and what we're seeing. So it's not tangible to the eye to see the difference. We've got a really agile telehealth IT team. And so when I go to them and say, hey, I want to do X, they come back and go, what about X times 10? And I'm like, fantastic. So we've got a really good, we've not had any IT problems, mainly because there's a huge push to adopt innovative new ways of doing things, but also to test and pilot them. So we've got a director general who's very keen to not keep doing what we've always done. So he's passionate about activating and encouraging individuals who may not have been, you know, they're a bit resistant with IT of we've always done it this way. They've now got individuals in there who have that same motivated, innovative mindset. So we're more than happy for my email to be distributed. And if you ever have anyone has any queries or questions about how we've done it, we're totally happy to hand over the whole rule book and the instruction manual, and so that anybody can deploy it in their region. We're also doing tele-ECG, tele-event monitoring, which we've added to, and we have a solution coming for echo in the near future, which next year you'll probably want to have another presentation about.
All right. Do you have another question there, Karen? You have your hand up. No, that's probably from the previous one. Adam, are you still there?
Yes, I'm still here.
Fantastic. Just one question from me. What is the cost involved in setting this type of remote technology, such as the ECG stress testing?
So the areas that we partnered with were already doing it. It's just the efficiency they were doing it in wasn't quite there. And so we didn't require to have to purchase physical equipment in those existing locations. We've got a lot of new different locations, like for example, at Rockhampton Emergency Department, have a lot of chest pain presentations, and we have this rapid access pathway where they come in and get their bloods and troponins done rapidly, and 2 hours later they get done again. And then they want them to have a stress test to rule out that it's cardiac origin. And they wanted to do it, you know, the cardiology department within Rockhampton Hospital weren't able to do it at any time of the day. So we had a treadmill purchased, we put it into the stress into their area in emergency. They used 2 existing nurses to be the local treating team, and we would just remote control operate it from there. All of our billing is done through activity-based funding through the Tier 2 30.08 code for clinical measurements. I think that was there anything else to your question?
No, that's fine. Thank you.
And from a staffing perspective, I should say, we are funded to have 2 cardiac scientists, an advanced trainee cardiology registrar, and 1 admin officer for those to be able to drive it into those 22 rural facilities.
Fantastic. Awesome. Any other questions from the floor before we end the session? I'm sure Robin has a question somewhere. Always. Oh, nothing?
I had a long chat with Robin, I think it was last week, and so she's probably heard all of this already.
Yeah, possibly. Are there any technical difficulties during sessions, for example, the ECG stress testing, and how often does it happen?
No, we've had very, very few. Like we've never we've probably done about 6,000 now over the last 7 years, and we've never had the system go down. We have backup redundancies, so that's why we have a local treating team in place. So if we drop out, they still conduct the test and finish it, and we come in on the phone or reboot the telehealth system. But we've actually had, that's probably only happened once in about 6,000 tests, and that was a user error on their end rather than a breakdown in the actual system.
Yeah. Wow. We probably have more technical difficulties with us being on site, so that's fantastic. Okay. So if there if there aren't any other questions for our speakers, we'll end the session here. But just a reminder that after this session ends, you will receive an evaluation form with just 3 questions. We would really appreciate it if you could take some time to fill this out for us. And just a reminder that for the next session, we have Dr. Shelley Keating coming in to Zoom with us to deliver a talk on remote delivery of objective measures, focusing on Module 9 of the Cardiac Rehabilitation Program. So thank you, everyone. Have a lovely day. And thank you again to our speakers today. Thanks, Alyssia and Adam. Have a wonderful day.
No worries. Thank you.
Thank you.
Thanks.